Greetings, this is Bob Harding. I'm a hospitalist at Riverside Health System, and I'm here to introduce the Riverside Care Difference and our safety initiative update to you. This program is going to last approximately an hour. When it's over, we hope that you're going to be able to say that it was time well spent and that it will improve your ability to meet our objectives. And let me get to those objectives right now. Riverside Care Difference has 4 basic tenets: keep me safe, help heal me, honor my wishes, be kind to me. We think that when we achieve these 4 characteristics, when they're part of the experience, that we will earn the trust of the patients that we serve. Trust is an extremely important entity. When people trust you, they come back, they utilize your services. Trust is really the key to our success and the measure of the quality of our work. Just as an overview for patient safety culture, again, I think we've been at this for over 2 years. Every single person who's employed by the health system has gone through safety training, and the announced goal at the beginning of that tremendous effort was an 80% reduction in serious safety events. Right now, we're at 62%. In this program, you're going to see a video done by Dr. Shivers, which will reintroduce and reacquaint you with the major safety characteristics, traits, tools that we can use that we know are effective at reducing serious safety events. It's a journey. We're well on our way, but we have not yet met our goal. We have been very good at detecting and correcting errors. We're now in a phase where we really need to be concentrating on preventing errors. And to prevent errors, it's going to take real, true physician engagement and leadership. As part of that, we want you to introduce you to the concept of what is a highly reliable leader. There are 3 aspects of that. You will set the tone around our core values, that safety will be paramount, will be first in everything that we do. That we will be encouraging reporting, because it's the reporting of errors that allows us to find the defects in our system and our behaviors. And that we will be thanking those who voice concern, so that there is no inhibition in any way for people to be speaking up when things don't seem right to them. The second aspect of this will be finding problems and fixing the causes. Physicians really do play a key role in that. So we are going to be safety champions. We'll be leading daily safety huddles. We'll be reporting when we find defects in the various measures we have to prevent errors. So most of you have been acquainted, I believe, with the Swiss cheese model and the notion that for a serious safety event to actually occur, typically many errors need to occur because we have many systems that prevent errors and that correct it before it actually gets to the patient. And yet, on a few rare occasions, increasingly rare thankfully, those holes line up so the error actually does get to the patient. So part of the engineering that needs to go on here is that we need to be looking at the holes, and if we can reduce the holes, the size of those holes, we're going to be more effective at actually reducing the number of events. So looking for those system fixes is something that the physician is in a unique role to do, and we want you to step up to that role. Thirdly, build accountability. So accountability is you're walking the talk, you're influencing others, you're being fair and just in acknowledging mistakes, not punishing the honest mistakes, but really looking for the solutions so that the next mistake does not occur. We have a safety video that will reacquaint you with the principal tools that were introduced when you first took the 2 or 4 hour course that all of us went through. These people that you're seeing are not professional actors, they're Riverside volunteers. We're illustrating for purposes of illustration, not true authenticity. So if you see something that's not quite clinically correct, please, a little forbearance there. The issue really is to understand the safety behaviors so that you can be incorporated into your daily practice lives.
As you know, Riverside launched our transformation to a culture of safety in 2011. Together, we've accomplished a lot, including reducing our rate of serious safety events by over 50%. While we are and should be proud of this, we still have much work to do on our journey to zero events of harm. While changing culture is hard, it is our culture that determines how we behave, and it is our behaviors which determine how our patients fare during their Riverside episodes of care. One patient who is harmed while in our care is one too many.
Please, we're asking you to take the time right now to focus on this short video. It will make Riverside a safer place for our patients, our residents, and our team members. We will work in high-risk situations that increase the chance we will make an error. We're under intense pressure, sometimes hurried, often fatigued. We can avoid most errors by practicing these low-risk behaviors. You're already familiar with them. They're contained in the Team Up for Safety Toolkit. Tools such as using three-way readbacks and repeatbacks for ensuring clear communication, and using the STAR technique to prevent those skill-based errors. So for the next 20 minutes or so, we will role model these behaviors. Our intention is that by giving you a clear demonstration, it may help you adopt these behaviors and tools and use them even more often and more effectively. Thank you for your close attention to this video. Let's work together to memorize and practice these simple safety tips for the sake of our fellow team members, our patients, and our residents.
Behaviors you're about to see are expectations, no matter what your role in Riverside Health System. Welcome to Safety Culture 101. Our goal today is to enhance our culture of patient safety and to examine how each of us can contribute to a safer patient experience. First, we will define our 5 safety behaviors and the error prevention tools that support each of those behaviors. Then, we'll examine ways to apply these error prevention tools. We will analyze some common medical errors and then examine the need for peer cross-checking and coaching. Finally, we'll examine the value of physician leadership as it applies to patient safety, and we'll look at the idea of power distance. The safety behaviors we will discuss today are: practice and accept a questioning attitude, communicate clearly, hand off effectively, pay attention to detail, and be accountable. Each of these safety behaviors has at least one error prevention tool designed to help avoid lapses in safety. This video will demonstrate how these tools, when used consistently and effectively, will improve patient safety throughout our health system. Let's talk about our first safety behavior, practice and accept a questioning attitude. Our main tool to practice this behavior is stop, reflect, and resolve. This is really an internal mechanism or self-check when something doesn't fit with your expectations, what you know and expect to be true. The most important step is to stop in the face of uncertainty by listening to your reflect detector and then do whatever it takes to resolve your concern. Remember, it's okay not to know, but it's not okay not to find out. Let's see what happens when a question of safety comes up in a practice setting.
Dr. Burgess, do you want any pre-op antibiotics on this patient?
Yeah, let's give her a gram of penicillin if she's not allergic to it.
I'll check on that. Dr. Burgess, it looks like she does have an allergy to penicillin.
In that case, let's give her 80 milligrams of gentamicin, please.
80 milligrams gentamicin.
That is correct.
Will do.
Our point here has been to introduce the idea of practicing and accepting a questioning attitude, which has enabled our nurse to speak up to the doctor. It is important to note that both sides have a responsibility here. Practicing a questioning attitude means speaking up when you have a concern, but just as important is the acceptance of the questions. When the doctor tries to shut down the question, he is risking patient safety. Our next safety behavior is to communicate clearly. In order to help us communicate clearly, we have adopted several error prevention tools. IS-bar-Q for the transfer of information, three-way repeatbacks, three-way readbacks, asking clarifying questions, phonetic and numeric clarifications for sound-alike numbers and words. For the IS-bar-Q tool, remember the following. IS-bar-Q stands for I, introduction, who are you or who are you talking about? S, situation, what's the immediate problem or the bottom line? B, background, the review of the pertinent information. A, assessment. I think the problem is, or my assessment is. R, recommendation. What's your recommendation? A request of the other person. And finally, Q, questions. Do you have any questions about the information that has been communicated?
Hi, Dr. Gasink. I know you're covering for Dr. Ward. This is Rebecca on the skilled unit. I'm calling about Mr. Bloom. He's a patient here. He had a hip fracture. He was discharged from the hospital. 3 days ago, I think. He had a hip fracture, and he's on Coumadin, I think.
It doesn't take long to recognize that our nurse seems frazzled and her verbal report is disorganized. Has she taken a moment to think it through, to write it down, to describe the situation, give the background, offer an assessment, and make a recommendation? It might have gone more like this.
Hi, Dr. Gasink. This is Rebecca on the skilled unit. I have a situation. Mr. Bloom fell out of bed 15 minutes ago. Unfortunately, I left his bed rails down while I was emptying his bedpan. He doesn't have any signs of injury right now. He is a little lethargic. His background is that he's a patient of Dr. Ward's. He had an ORIF for a hip fracture a week ago, and he came to us on the unit 3 days ago. An hour before he fell out of bed, he was given 4 milligrams of oral Dilaudid for pain. My assessment is that there's no evidence of injury right now, but he may be lethargic from the Dilaudid that he received. I'm recommending that your nurse practitioner maybe evaluate him for the drowsiness and that we get an INR. Just observe, do neuro checks every hour. Any other recommendations or questions?
Clearly, the ISBAR-Q format helped our nurse organize her thoughts and is a model for all of us as we strive to communicate clearly and to hand off effectively. Now, let's see how a three-way repeat back works. First, the sender initiates the communication. The recipient must acknowledge the communication with a repeat back, and then the sender must acknowledge the accuracy by saying, "That's correct," one of our key safety phrases.
Hello, this is Dr. Gasink.
Excuse me, Dr. Gasink. The potassium on Mr. Smith is 4.2.
Mr. Smith, potassium 4.2.
That's correct.
That's how it works. And now, a three-way readback.
Hello, skilled unit, this is Rebecca. Hi, Dr. Gasink. I just wanted to let you know that the hemoglobin on Mr. Smith is 8.2.
You know what? Let me write that down.
And his hematocrit is 24. That's 2.4.
Mr. Smith, the hemoglobin is 8.2 and the hematocrit is 24. That's 2.4.
That's correct.
This is the patient's baseline, so no orders at the moment. Thanks so much for calling.
Another important tool for communicating clearly is the clarifying question. This technique ensures that you don't make an incorrect assumption.
I have a clarifying question about Mr. Harris. The family had mentioned that he's allergic to penicillin. Did you mean to prescribe Keflex? I know there can be cross-reactivity between the two.
Yes, I meant to order Keflex. I clarified with Mr. Harris's family that his allergy to penicillin was minimal and that he had Keflex in the past and tolerated it without difficulty. Thanks for the clarifying question.
Phonetic clarification is used during verbal communication when words sound alike. It is often helpful to use phonetic clarification for drug names and for patient names.
Is this Mr. Brent or Print?
This is Mr. Donald Brent. That's B as in boy.
B as in Bravo, Brent.
For sound-alike numbers, use numeric clarification. Say the number and articulate each digit. 15 and 50 can sound alike.
Was that 15, that's 1-5, or was that 50, that's 5-0?
For a complex number such as 425, articulate each digit, 425. In addition, the number such as 425 can sound like a range of 425. Therefore, we want to insert the word dash for ranges. It works like this. That's the range 4-5. For our next safety behavior, handoff effectively, we'd like to focus on the 5P handoff tool. Within our health system, patients must routinely move between facilities and between providers. Nationwide, poor transitions of care are one of the main sources of medical errors. At Riverside, we can turn this into a strength by consistently using the 5Ps. Let's watch how this works.
This is Ms. Elizabeth Taylor. She's a patient of Dr. Cavitt's. The plan is to transport her to CT to have a CT scan to rule out PE, as she's been having chest pain and shortness of breath. She does need to stay on the cardiac monitor. She is also a fall risk secondary to medications. She has been given nitro and morphine for her chest pain.
All right, just to clarify, I'd like to repeat back. This is Ms. Elizabeth Taylor, Dr. Cavitt's patient. She needs to go to CT to rule out pulmonary embolism. She has chest pain and shortness of breath and will need a cardiac monitor. She's also an increased fall risk due to the morphine and nitro she's received. Is that correct?
Yes, that is correct.
Ms. Taylor, my name's Desiree. We're going to take you over to CT, and we're going to take great care of you today.
Thank you.
We need to take extra precautions when patients transition from one facility to another. Here's an innovative way that Riverside Tappahannock Hospital and The Orchard are assuring that an effective handoff occurs.
As patients move from caregiver to caregiver and provider to provider, it's critical that information about their treatment goes with them. Either within the hospital or during a transfer to another department or facility, this patient transfer or handoff is a critical moment, and if not handled efficiently, vital information about a patient's health may be misunderstood. This is why Riverside Health System has implemented the 5 Ps: patient information, plan of care, purpose and desired outcome, precautions, and problems. Here is an example of the 5 Ps implemented between 2 Riverside affiliates.
This is Mr. Brown and his daughters Amber and Kelly. Did you get the 5P that I faxed?
Yes, I have it ready.
Okay, a little patient information. This is Mr. Joe Brown, 60-year-old white male who came to us on the 2nd and had a left total knee replacement. He has an allergy to latex. Did you see that?
I do see that. I'm going to read that back to you. He's got an allergy to latex.
That's correct. Do you have any questions, Charlotte?
No, it sounds like it's complete. Thank you.
Okay, they'll be bringing him over, so expect him around 11:30.
Okay, sounds good. We'll see you when you get here.
Thank you, Charlotte.
Thank you.
Thank you.
Right.
Have a good day.
The 5 Ps is an effective and efficient process that helps the Riverside Health System ensure clear communication during patient handoffs.
The 5P handoff process is not meant to be a burden. Use it where it's appropriate, such as change in shift, a change in level of care, or a transfer to another Riverside facility. Our patients depend on us to do this. Let's now talk about the safety behavior of paying attention to detail. The error prevention tool we have adopted to help us pay attention to detail is a mnemonic called STAR. This is meant to reduce the honest, skill-based errors that are so easy to make. S stands for stop. Pause for 1 to 2 seconds. Think about what you intend to do. Act, perform your task. And finally, review. Check that you obtained the desired result.
Hey Sarah, is this hemoglobin correct on this patient?
Let me just finish what I'm doing and I'll be right with you.
Okay, thank you.
Yeah, that patient's hemoglobin didn't come up after the last 2 units of blood.
Okay, great. Thank you.
You're welcome.
Mr. Smith, we're ready for you. Mr. Smith. Mr. Smith.
Oh, you go ahead.
All right, thanks.
Good afternoon, Mr. Smith.
Good afternoon.
How are you today?
Good. You?
Good, thank you. Please have a seat right here.
Okay. Sure.
Could I please have your full name and your date of birth?
John William Smith, June 1st, 1970.
Could you please repeat the date of birth?
June 1st, 1970.
It looks like we have you mixed up with another John Smith. This happens more frequently than you think. This is why we double check your birthday. So if you give me a minute, I will go get the corrected chart, okay?
That makes me feel much better.
Good.
Our final safety behavior is be accountable. In this behavior, we look out for one another by taking responsibility for our own safe behaviors and supporting and sometimes critiquing our peers and coworkers to ensure a safe patient experience. Let's look at one of our tools that supports accountability. Speak up for safety using our CUS words. The acronym CUS stands for concerned, uncomfortable, and stop, and is used to escalate a situation. Remember, you don't need to be right, you just need to be concerned. Our patients and their families are trusting you to follow through on that concern until you're certain that they are safe.
Closing up here, we'll be done here in about 5 minutes or so.
Okay. I'm concerned I'm missing a pair of pickups.
Definitely not up here. Look on the floor and the drapes.
I've looked on the floor. It's not there.
My hands are in the abdomen, and I know it's not in here.
We've lost a pair of pickups, and I don't feel comfortable moving forward with the procedure.
I think we should just continue. We're about done.
We're going to need to take an x-ray.
Listen, I don't want to waste an hour waiting for x-ray to get here to take a plain film to confirm that there's no instrument left inside her belly.
We need to stop the procedure. It's very important that the count is correct, and it's not. We need to stop the procedure and take an x-ray.
You're right. Thank you for speaking up. Call the x-ray tech and see if we can get him in here to do a quick x-ray.
Can you call an x-ray, please?
Being accountable to patients and families means speaking up when you have a concern. Part of that accountability is using cuss words in the appropriate situation. Our point here has been to introduce the idea of practicing and accepting a questioning attitude, which has enabled our nurse to speak up to the doctor. It is important to note that both sides have a responsibility here. When practicing a questioning attitude leads one to voice a concern, not only does that individual need to speak up, but the question must be accepted. It is just as important that the doctor accepts the nurse's questioning attitude. When he tries to shut down the question, he is risking patient safety. We use the words concerned, uncomfortable, and stop to make sure that we are taking any safety concern seriously. And remember, we're always to practice and accept a questioning attitude. It is important that the physician recognize the value of the cross-check and accept the nurse's questions, not as a personal attack, but in the best interests of the patient.
Safety is the singularly most important thing we do. If we can't do it safely, we're not going to do it at all. We are counting on all of you to stay the course, to help our commitment to turn the Team Up for Safety behaviors into real habits that protect our patients. These behaviors and tools set clear expectations for every member of the Riverside Health System team. Regardless of your role, our patients can only be protected when we all make these habits our own.
My name is Tiffany Christensen. I am from Durham, North Carolina. I work at Duke University Health System. I work professionally as a patient advocate in Duke Hospital, primarily in the area of oncology, but I also serve as a patient advisor for Duke Hospital in helping them to expand their patient advisory programs. I've been a patient since I was born, so healthcare is something that in a weird way I've been comfortable with and equally uncomfortable with throughout my whole life. And I think that at some point it became something I started to become fascinated by. That exchange between patient and family and provider is something that is so delicate and something that is so hard to perfect that it became an interest of mine to start to talk about the patient experience. I guess you could say one of my strengths and weaknesses is that I am very outspoken, and so it became something that I was comfortable talking about and sort of expressing what it feels like to be in the bed. And through that process, I really began to listen to what it feels like to be standing by the bed. And it was that listening that allowed me to really become engaged in this conversation of How do we do this together as a partnership? And to me, that is a fascinating question. We look at things like hourly rounding. We look at things like bedside shift report. Those are things that are standard or becoming standard tools, best practices. Those are wonderful things to operationalize person-centered care. At the same time, as a patient, I know that my greatest moments of partnership have not necessarily come because of a tool. They've become because of the individual who's standing in front of me respects me as a human being who knows my body, who has a history with healthcare, who has a history with this illness. And now we're partnering and talking about what is realistic for me. What am I actually going to do when I leave? Am I really going to do 17 nebulizers a day? No. And so the providers where I find partnership are the ones that are willing to look at me and be honest and allow me to look back at them and be honest. And that's a rare experience to have. I think it's becoming more and more common, but as my time as a patient evolves, I can look back and say that there were many providers that I lied to, many providers who probably didn't mind that, because what they really wanted was to walk in, give me a prescription for a care plan, have me nod my head and leave. And now we're looking at what does that feel like, or how does that function when we're honest with each other, and I get to tell you, you know what, I'm not going to do those 17 nebulizers, so let's talk about what I can do, and let's make a care plan that's realistic and that both of us can feel good about. And that, to me, is something that is so personal that it's really hard, and that's why I think what we're doing is so hard, because there's the big picture, but where the rubber hits the road is those moment-to-moment interactions. And that's hard to put on a piece of paper, and that's hard to say, here's how you do it. It's really so personal. One of the greatest ways to affect change when we're talking about person and family-centered care is through story. To take the patient family advisory council and allow them the stage for which to tell their story in an effective way to the people who are going to then be motivated to implement those new programs, to change those policies. And for me personally, one of the greatest examples of that was a little talk that one of our advisors gave. It was a very short talk. It was about 15 minutes, which as a person who gives talks, you think, what can I do in 15 minutes? That seems so small and trivial. But what ended up coming out of that little 15-minute talk was a doctor sitting in that room who said, oh my gosh, I've been doing this wrong. All this time, I have not been engaging my patients and families in a way that is to the benefit of all of us. And so from that moment, from that little 15-minute talk, she decided to change the way that she did things, and she implemented pretty quickly a whole program around patient and family-centered rounding. So the way that she rounds on her patients is very different. The way that she preps her patients in the outpatient areas is very different, and now the whole continuum of care for her patients is very different because she set the stage in a completely different way. And that all came out of, and that doesn't happen with one doctor, that has to happen with the nurses and everybody else who's rounding with that physician. That is a culture change within one surgical area, and that all came out of one patient story told on one day in 15 minutes. And that is a great example to me of how what one little pebble can be such a huge ripple, and you may not even know that all of that came from one story.
I think the Tiffany Christian video really does help to bring home the importance of respecting each individual for their individual circumstance, and the need to be able to communicate effectively to get that unique solution. And I think it is a unique solution for each patient to get the best possible outcome. So the thrust of the Riverside Care Difference and this talk is to help you have tools, just as we do with safety, that will improve your ability to connect with patients, to communicate effectively, and why that's important. We'll talk about that a little as well. To summarize, we're going to talk about 10 specific behaviors that Press Ganey, the company again that's doing the surveys and has a wealth of experience analyzing what is effective in terms of improving patient sense of satisfaction, the sense that they've been well cared for. How do we actually get improvement? And so when you get down to the sharp end of the spear, and you guys are all the sharp end of the spear, what can you do on a daily basis that makes a difference to your patients? And so hopefully at the end of this, you're going to be able to say, I can do a couple of things differently, and I think it really does make a difference. These things do make sense. There are 3 categories of these 10 talking points. First is positive regard, and the second is active listening, the third, effective explanations. So just as a way of introduction, the positive regard starts with a heart, head, heart perspective. And when I first heard this, I really had a hard time getting the sequence, but I think what it really comes down to is when we're going into an interaction with a patient, we are tending to be dealing with the objective, what's the problem, what are we going to do about it, whereas the patient's perspective is they're feeling it. What we want to help us understand is that when we acknowledge how they are feeling, and that's the first thing we do, there's a connection there that enables our further work to be much more effective. So leading with heart statements that reflect the emotion that a patient is bringing to an encounter turns out to be a very effective strategy that will improve the way we do our work. So active listening, there will be a number of different aspects to the mechanics of how the visit goes that help with active listening. And thirdly, the effective explanations, using plain language, using a teach-back technique to confirm that people do understand what you want them to get out of the visit. Just a word about the patient experience. I think it's easy for physicians to feel jaded, perhaps a bit cynical about what the patient experience is and how important it is. Let's just talk a little bit about what it is not and what it is. Patient experience now is mission critical, and it's mission critical because it involves safety, it involves respect, it involves patient rights, it's a differentiator, it has important financial repercussions, it has repercussions because it tends to be a measure of how well we're doing. It is not about delight and wow. It's about mitigating unavoidable suffering and preventing avoidable suffering. And I want to repeat that because I think it is, in many ways, maybe the most important aspect of what it is we do. We mitigate unavoidable suffering and we prevent avoidable suffering. And that's what the care difference is all about, is maximizing that effect. It's about focusing on systems, processes, skills, behaviors that inhibit that or enhance it. That's really what we're talking about in the care difference. So on a more practical level, if you will, why are we important? Why is this? Why are you, as a caregiver, is it important to you that patients have a sense that they've been well treated, that the experience has been everything it can be? So if you're a clinician, these things are going to be important to you. When people have a high sense that they've been treated well, a good patient experience, their patient compliance is better. So if you think that what you're recommending to people is helpful to them, the patient goes away feeling that the encounter was one in which the provider did not truly care about them, did not understand them, did not give them information that they could act upon that made sense to them, we will not get compliance. If we don't have compliance, we will not be getting the results that we want. We know that when people are satisfied with their care, that the number of preventable readmissions goes down. We know that the cost of care is reduced. On a more personal level, we know that when people are satisfied, that the likelihood of a litigation for an untoward event is significantly reduced. So we have many reasons for both in terms of outcomes as well as for our personal liabilities to be paying close attention to this. Good patient satisfaction, we know, translates into loyalty. And we know that loyalty leads to patients continuing to use our services. It also means that they recommend our services to their friends, neighbors, and family. Most of us who have been in practice for some time have built our practices on word of mouth. And I think despite all the other ways of directing care, of social media, that patient recommendations on a personal level to their peers, to their neighbors, is how practices are built. And we are a group of 550 providers and probably 100 or 150 different practices that are going to be built one at a time with that type of person-to-person interaction, recommendation of your services, and return service for a job well done. Press-Ganey, in their analysis, tells us that the key drivers of patient loyalty include confidence in the care provider, your ability to coordinate care. That really does, what that means is how well you are able to communicate with the other people on the team that also provide care. Concern that you providers show for patients' questions and their worries is a third component of loyalty, our ability to listen and the courtesy that we provide. Those are the major drivers from Press-Ganey, and those are things that we feel when we incorporate the care difference into our practices, that we will meet those measures that reflect, in the end, patient loyalty. Patient satisfaction, patient measurements of satisfaction are no longer an option. They really have become an expectation. Now, we certainly see that from Medicare, but we also see it in our professional societies. If you're going through maintenance of certification, now many of the societies are requiring assessments of your ability to effectively clinically communicate as being one of the requirements to get recertification. In our medical schools and in our residency programs, we are routinely sharing patient satisfaction and trying to educate our new providers as to its importance and also how it can be effectively accomplished. So for those of us who've been in practice for many years and haven't had the value of that type of training, this is an opportunity to get that kind of training. And finally, we know that there are many financial incentives, whether you call it pay for performance or provider-based reimbursement. We know that a portion of our reimbursement on the system level, on the facility level, and eventually on the provider level is going to be tied to patient satisfaction. To those who think that may involve pandering to people, giving them what they want, I would say that we are not asking for suspension of your clinical judgment, of your professionalism, and nor are your patients. Your patients are asking for your best judgment as to what makes sense for them. And I think when that is delivered in a thoughtful and respectful way, even if it's not what they want to hear, that it will be respected. Okay, well, let's talk about some of those 10 behaviors that I've mentioned that we think can be easily incorporated into your practice. And again, I want to say that I think it's probably safe to say that the large majority of you are probably using these 10 behaviors fairly regularly. On the other hand, it's probably also fair to say that it would be the rare provider that's using all of them, and even rarer to say that any one of us doesn't have room for improvement. So key behavior number one is this head-heart concept. And it really has to do with trying to be empathetic from the start, that we want to acknowledge how people are feeling, we want to be respectful. So the mechanics of that are things that are pretty straightforward. So it starts when you enter the room, that you knock, that you actually wait when you knock to hear a response that it's okay to come in, that you use the patient's preferred name, that you are pronouncing it correctly, that you introduce yourself. Perhaps you give a card so that the patient is able and the family is able to remember your name. If you're like me, I can easily forget a name halfway through the conversation. So having that card, I think, is helpful. Apologize for waiting. think that shows a sign of a respect for our patients and their families' time. And we who frequently do run late, if anyone should be respectful of that, it should be us. Shaking the hand and looking patients in the eye, absolutely key to making that fundamental touch of physical contact of the bond that's about to be either initiated or to be reconfirmed. We think it's preferable to sit down. Many of you may know that there are studies that if you look at patients' sense of how long the physician spent with them, if the physician sat down, if the provider sat down, the patient's perception of how long they stayed with them is substantially larger than if the provider stood throughout the visit. Same length of time, but the perception of time spent is different when you sit down. What you're really saying is, I have time for you. I think it's important to be able to verify information and to set the agenda. That's a challenge for all of us in a time-compressed world. We want to be able to go in and be prepared to know what the issues are, to know some of the appropriate background, and perhaps to set realistic limits as to how many issues can be addressed at a given visit. Then we go through our exam, our history, our head portion of the visit, and that's the nuts and bolts that I think all of us are pretty capable at. Again, though, at the close of the visit, we want to go back to those heart types of behaviors and statements which help, again, to reconnect with the patient and and re-emphasize to them that we care for them as an individual, respect them as an individual in their special circumstances. So some of the mechanics of that are to reiterate what the understanding is of what the issues have been discussed, that you provide resource information when it's appropriate, that there's an empathy statement in terms of the difficulty that a patient or family may be dealing with because of a health circumstance, that you shake their hand, that you thank them for coming, and that you'll make sure that any follow-up is necessary is in place. So again, heart, head, heart. Second key behavior is narrate care actions. This is, I think, a fairly simple point, but what it speaks to is that we do things in a visit that may be entirely routine and regular for us. And yet, for the patient, they may not have any sense of what it is you're about to do. So announcing what you're going to do in the sequence and whether there's going to be any discomfort associated with it or any effect on their modesty, perhaps, that they're given a chance to be warned and forewarned and reassured about what is to be happening next in the visit. In a hospital setting, paying attention to be anticipatory of needs would fall into this category. Again, in the hospitalist world, we have patients who are being mobilized, they have pain, they're being seen by physical therapy. So one example would be a patient telling you that they're having pain, the therapist is telling you they're having pain, they really can't participate as much as you'd like. So you make sure that you acknowledge that is a barrier to getting the help that they need, and you're going to make sure that they have adequate pain medication at an interval before the physical therapy actually occurs so that they can get full benefit of that therapy. So narrating your care and your actions prior to instituting them, key behavior number 2. Key behavior number 3 is respectful inquiry. This comes in many forms. So it's eliciting people's perspective about their own illness. What do they think is causing the problem? History taking 101 is, if when in doubt, ask the patient, and certainly this falls into that category. But it addresses what the patient may fear is going on, not so much what is going on, but addressing those fears is very important, and if you don't address them, people will feel like you were not listening. So I think it's important that you not be dismissive of those concerns, but that you provide a reassurance that you're listening to them and providing your own sense of assessment and plan. And thirdly, that you have an empathy statement that reflects how a disease process or condition or a procedure might be impacting quality of life, their ability to work, issues that are frequently paramount in the patient's mind, although we tend to concentrate on what we're doing, not so much on what it is doing to the patient. I think being mindful of that really helps to establish the connection that we are truly caring. Non-judgmental curiosity about their health beliefs, being sensitive to the variations in health beliefs and what people see as realistic goals for them are, again, a hallmark of a good care and part of a respectful inquiry. And that's key behavior number 3. Going to the next block of the 3, and this is the power of presence, active, empathetic listening. This slide describes visually the importance of what's important in communication, and every time I see it, I'm a little bit flabbergasted. So if you look at the attributes of communication, verbal, visual, vocal, you'll see in the slide that 55% of the impact of communication is in visual, 38% of vocal, and only 7% in verbal. Now, I would have easily thought that verbal would be the most important. After all, people are there to hear, I think, what I say, what I think, and yet how I deliver it and my tone of voice and my appearance turn out to be much more important than what I'm actually saying. It's not to denigrate what you're saying, but if you can't say it in a tone of voice that is reassuring, we're not going to get the kind of results that we could. Nonverbal ways of communicating, very important in the end result of people's perception of how well you communicated with them. So next, key behavior number 4, the 3 Ps. These are the mechanics really of how you do the individual visit. I think they're important. I'm not sure we need 3 Ps, but they are pose, pause, and peer. And so simply pose that you position yourself within 5 feet. Now, I don't know where the 5 feet came from, if there's any real statistical validity to that, but I think the notion that you're reasonably close to the patient at a distance where it becomes clear that you are there focusing on them and that the other distractions in the room have been minimized. I think that is very, very important. You want to mirror the patient's face as much as possible. You want to make sure that you're not turning your back or turning aside when you're communicating important information or you're receiving important information from the patient. You want to be still. That's the pause aspect of it. If we're moving around, again, it's an indication that we're not paying attention, that we're not engaged in the moment with that patient. And finally, the peer, that you're looking directly at patients, again, when you're receiving or giving information. That aspect of communication is absolutely key. So, key behavior 4, pose, pause, and peer, the mechanics of the actual interaction. Turns out to be, again, an important way of easily giving people a sense that we're caring and that we're involved. Key behavior number 5, transitioning attention. So we live in a world in which there are many demands on our attention, and despite you close the door in the room and you have privacy, there's still interruptions. So those things are hard to avoid. And one of the principal ones I think that bears particular mention is the computer. Computers are almost in most of our rooms, whether they're in an outpatient setting or in the hospital. Being able to make sure that the presence of the computer is not becoming a symbol for not paying attention to the patient, so that when you are turning to the computer, that you make a formal break point so that people know that some reflection, well, I have some things, let me check on that, and you break, do it, and then, or make a notation so that people realize it's part of the job, but it's not interfering with the communication. I think that's really the essence of this particular point, that you may make a transition of attention, acknowledge that there is this interruption, but it's a necessary one, but you still have my involvement. Sort of a corollary to that is key behavior number 6, and again, that reflects the mechanics of our world. Take advantage of that computer, take advantage of that technology to be able to demonstrate to people perhaps imaging, perhaps previous lab tests, graphing things for them so that they can see the value of the technology and not look at it as an intrusion. Key behavior number 7, minimizing distractions. I touched on this a little bit with the previous description of key behaviors, but distractions are something that are hard to avoid. In my world, in the hospitalist world, we're walking around with a pager and a cell phone and maybe an internet phone. Interruptions are part of virtually almost any encounter. You can count on getting a page. So what we would suggest, and what Prescani is suggesting, is that you try to be mindful of your personal circumstance, your personal practice circumstances. What are the major distractions, and what can you do in a mechanical way? This would require not so much in the individual visit. What can you do in a mechanical way that takes those distractions out? How can you re-engineer it so that those things, so you don't have those interruptions, so that the interruptions are dealt with outside of the actual patient encounter time? So that there is not that interruption during that very personal period of communication. So making a plan to reduce distractions is something that we hope that you will take away from this session. We also think it's helpful to be able to acknowledge to people that a distraction may occur. I'm on call. I expect a call from the emergency room in the next 15 minutes. I may have to step out to take it. I think things like that people are certainly respectful of and don't look at it as an interruption that is taking away from their time with the proper explanation. Empathy, we've talked about empathy and empathy as being particularly important, and we do because it really, I think, goes back to that statement earlier about relieving avoidable suffering or mitigating unavoidable suffering. And what the empathy statements do is do just that. They help reassure people that there's someone there that's listening and cares. When we've developed this program, we came upon this video, which I think very effectively demonstrates how empathy looks and feels.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you can climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
I hope that that video did resonate with you. It certainly did with us. Empathy is the understanding and identification with another's emotional state. Identifying with another's emotional state. Very powerful. When we do that, when we employ empathy statements, we prompt people to give us more information. It allows them, it enables them, it empowers them to be more open, to be more forthcoming. It indicates that you're listening, and it demonstrates your true caring. It tends to diffuse the highly emotional responses that sometimes can be part of a visit. And it helps prepare the patient to listen to you, because they're now engaged with you. So empathy statements, very, very important. So key behavior number 8, the empathy statement. So we think that should be part of every encounter. And again, going back to that head-heart concept, empathy statement fits into that. So it's a descriptive word. The statement would be a descriptive word or term or phrase that indicates that you understand what the patient is going through. Not that you're sympathetic, but that you understand it. It's stopping to let allowing silence to have people reflect on what you've said and allow them to be forthcoming with more detail. It's probing, open-ended questions to allow deeper discussion when it's appropriate. So, key behavior number 8, the empathy statement, very powerful. Finally, the final trio of key behaviors, the power of informing effective explanations. First aspect of that is plain language. I think it's easy for us who spend a career with a vocabulary that is foreign to most people to forget that our terminology can be off-putting, can be a source of confusion, of intimidation for patients. It really doesn't lend itself to good communication. Good communication is that people are going to understand what the information you're trying to impart to them. So it has to be given in a way that it can be understood. So it's easy for us, again, to dismiss this, but it's, I think, quite powerful. So just as a brief explanation or examples, when we say physician, well, we know what a physician is, but they know you perhaps as a doctor. When we say malignancy, they may know that better as a cancer. Fatigued, being tired. There are simple things, but that I think being aware that the choice of words helps the patient understand what is truly going on is a more effective technique than using words or terms that are really barriers to understanding for many people. So having a sense of patients' health literacy is quite important in terms of effective communication. Key behavior number 10, the teach back. Again, if I can take an example from the hospitalist world, we ask people all the time orientation when we're admitting them, so that you know what year it is, do you know where you are, that sort of thing. And it's almost invariable that people, when you ask them where are they say, I know where I am. But when you ask them, well, where are you? They think they're home. They think they're in a convalescent center. They really don't know that they've been moved to the hospital. And when you ask them what year it is, it may not be 2015. It may be 1933, the year they were born, or some other year that has absolutely no relationship. So the point that we're making here is that when you're giving instructions to people, they are going to nod yes, say they understand. The key to making sure they have understood is the teach back. Key behavior number 10, the teach back. What that allows is for the patient to express in their own terms what was the message that you were trying to get across. What was the diagnosis? What's the procedure we're going to do? What kind of testing? What's going to be the follow-up? Those key aspects to make sure that the patient or the family, patient and family, understand what the key elements of what you're trying to impart to them are in fact understood. And the patient or the family nodding yes or saying yes they understand without demonstrating teach back is clearly an area where we can improve, because when we do the teach back, it's very informative as to where we are in terms of the effectiveness of our communication. So those are the 10 behaviors. It's a lot of information. I'm thinking it's 7 too many, but on the positive side, I really do believe that most of us are using many aspects of these various behaviors, but there's almost nobody out there, I'm willing to venture, that can't benefit from some of these techniques to improve the quality of the interaction with the patient as perceived by the patient. And that's really the key. It's the quality of the interaction as perceived by the patient. So what we're asking is to contemplate in the days ahead these various lessons, see which ones you're using and are reinforced, and you congratulate yourself that you already knew all this stuff. But on those few things in which you can improve, which you're not using, which have been demonstrated to be effective, we ask that you incorporate those into your practice. We do think that they'll be effective at improving our patient satisfaction, and we know that when we have that, we're going to have better outcomes, we're going to have better compliance, we're going to have better cost utilization. And we think when all those things happen, we're going to feel better about the quality of our work. So in the end, this is as much about physician satisfaction as it is about patient satisfaction. When we do a good job, we feel good about ourselves. This is a way of doing a better job. Thank you very much for your attention. Thank you very much for what you do for each of your patients and your communities every day. Thanks.